This is part 2. We just did a very brief film with Jim walking. And after that, you said some interesting things. And I can't remember the comment you made after we stopped filming. But it was something about how this leg behaves differently than the other one. Can you recall what you said?
It doesn't absorb the impact. It tends to collapse underneath me as I stride out.
Aha. At what part does it do that?
Pretty much, lifts up fine, but reaching out, an extension, and then dragging through.
So at heel strike, is that a fair statement?
Yes, pretty much going to heel strike.
And then does it continue to mid stance?
Yeah, probably to that end.
And so it feels unstable?
Yeah, somewhat unstable. It's not quite as strong, but it's mainly just very awkward, I guess is the way to describe it.
And so you also note that it doesn't absorb shock well.
Correct, yes. Not nearly as much as that left leg.
And I certainly trust those subjective reports. And the last time you tried to get a diagnostic workup for this?
Oh, it's been years. I just became frustrated because they just told me there was nothing major wrong and just give it rest and it'll come around and stretch it and strengthen it. And I've done that for years and it's just gotten worse.
Who had you seen?
I had a person test my nerves because I told him, I said, I don't think I'm getting the right feeling down my legs, and he tested it and he says, all your nerves are fine, there's nothing wrong with you. And I had other people, look at my legs and hips and again just said, stop running and things will be fine. Well, I did that and things were not fine.
Right, so you resumed running.
Yeah, so I figured I enjoy it and I can still at least do it and enjoy it.
So did anyone do a hands-on evaluation of your knee or an MRI of the knee?
Well, I had a knee operation for a meniscal tear back in '03.
And yes, okay.
And all that, it's just, that was what I had, a meniscal tear. They didn't say why I got it or anything else. No.
All right. So after that surgery, was there any improvement?
No, it's gotten even worse.
Gotten worse, okay.
Now it's, before walking was okay, now walking is very difficult.
All right, I got it. Okay, so one thing that I find with respect to the feet is that you have rather, well, I'm almost going to use the term hypermobile. Your connective tissue in the foot and ankle is quite pliable, okay? These joints are quite pliable, quite mobile. And if we test eversion at the heel and inversion, and if we test medial rotation and lateral rotation, I can repeat those tests constraining the lateral medial malleoli, and you still have rotational mobility in the subtalar joint. You still evert and invert. And on this side, you do have medial rotation, but lateral rotation stops rather quickly, maybe 5 degrees only. And eversion, very limited there. You seem to have full inversion. And then if I constrain, compressing the malleoli, you still have that 5 degrees of abduction mobility, much less than the other side. And you do have a deduction mobility and no eversion there, and full inversion. So I think that you have this restriction in the subtalar joint that's contributory, but what I find at the knee is rather interesting. We already screened the pelvis, we screened your hip joints, I don't implicate them. And this knee, when we test hyperextension, I can't even get that leg off the table. This one I can get a little bit of movement. I can get a little bit of lift of the lower leg off the table. And this one, no. And when I bend it slightly in order to test anterior drawer, I don't get any anterior drawer mobility. If we test the left knee, there's a little tiny bit of give, a little bit of force transmission there. What's interesting is that when I bend this just slightly, I can actually induce a little bit of posterior mobility. And then when we come up to about 60 degrees, you have a distinct posterior translation of the tibia. And then at 90, same test. It's a little bit bewildering. I think that now maybe you can see the posterior and anterior translation here. And it's almost like a reverse Lachman's test. With a Lachman's test, when there's a tear of the ACL, 50% of the fibers or more, there's a distinct anterior translation, and I can't get any forward translation. But if I jostle it a little bit, you know, then I can get posterior translation. It just has a very peculiar feel to it, and I think your knee has a degree of instability, and maybe it involves the posterior cruciate. And this feels positive for posterior cruciate tear, except that it seems to get to a hard end feel quickly. It seems like it has excessive mobility, and then it has a stop. So it's a little bit peculiar. And if I test the medial collateral, that seems pretty stable. Stable in extension, stable in slight flexion. If I test the lateral collateral, that seems to be stable in both of those directions. If I test rotational mobility, you have a restriction here. This tibia does not rotate externally. This one has normative play. So I think that you may have a tear of the posterior cruciate ligament, and you have normative anterior posterior spring there, normative give on the tibia. Let's compare the other side. Feels fairly normative there. I think that you have a torn PCL ligament, and it could be that there's more damage than that. I'm a little suspicious. Now I can get a little bit of a drawer, so now I'm getting a little bit of a positive Lachman's. It's not excessive, so it does come to an end point, but there's a little bit of sloppiness there. And if you compare it to this side, and I think maybe you've just been able to relax, and here there's no drawer, there's no anterior yield, a little tiny bit of play, but no discernible movement. Okay, so I think that you have damage to the anterior cruciate, and perhaps greater damage to the posterior cruciate, because right here this is a considerable degree of posterior play. So I think that an MRI or a thorough orthopedic exam with a knee specialist would be informative on that knee. Nonetheless, I'm going to go ahead and treat your subtalar joint, because sometimes a mobility impairment down here can inhibit function in the knee musculature.
Right.
So we will take a look at that, and I'll screen your strength again, but we don't have any fancy equipment, you know. It's just a manual muscle test which has its limits. But we'll stop filming here. Just push the red button. Thank you.